Hi guys, so let's talk about chapter 19, which is endocrine and hematologic emergencies. And just for time's sake, I'm just going to use the PowerPoint that is straight from your book. So you guys already have this posted in your Blackboard this week for you as well. So the endocrine system influences nearly every cell, organ, and bodily function, and its main job is to maintain homeostasis. And so that's what it does with every release of every type of hormone. So we're going to talk about in this chapter some endocrine disorders that have a lot of different signs and symptoms. And then we're also going to talk about some hematologic emergencies, which can be difficult to assess and treat, but that can be potentially life-threatening as well. So the endocrine system is a communication system that controls the functions inside of the body, and it does this with hormones. And so these endocrine disorders are caused by an internal communication problem. And so as we are going to see when we dive into some of these, it's not always about a lack of a hormone. Sometimes it can be the way that a body receives that hormone. So we want to make sure that we're identifying what is potentially going on inside of the body. Even though it might not be our job to diagnose the underlying problem, we can treat the signs and symptoms based off of our patient assessment. So obviously we know by now that the brain needs an adequate supply of glucose and oxygen. Now what we may not know up to this point, and what this chapter is mainly focusing on, is that the body also needs insulin for glucose to enter cells. So what I want you to imagine is that the insulin is the ship and the glucose are the packages on the ship. Okay, so the packages, if you just throw them into the harbor, they're not getting where they need to be. They need to be on the ship to be able to be utilized properly. And that's exactly how insulin and glucose work. Okay, so the pancreas produces both glucagon and insulin, and it stores and secretes insulin and glucagon in response to the blood glucose level. So glucagon is a little bit different than insulin. Glucagon is a naturally occurring hormone just like insulin is. And when glucagon is released, what it's asking for is for glucose stores, usually from the liver, to be released in the bloodstream to raise the blood glucose level. Okay, and so what's not really applicable to you guys at the EMT level in regards to treatment, but that you may hear talked about as you're out working with your ALS providers, is administering glucagon in the field for low blood sugar. And that is actually something that we do quite often. And that glucagon, when we give it as a medication, acts just like the regular hormone when it's released in the body, and it asks for the liver to release the glucose stores there inside the body to naturally raise the blood sugar. Now, it does take a little bit longer, but it's a more effective and a lot better response from the patient. So just some things to consider, but it does take a little bit longer. So you might see that given in combination with intravenous dextrose as well from your ALS providers. All right, so just so we understand, glucagon and insulin, both hormones, both have different jobs. Now, insulin is absolutely necessary for glucose to enter the cells. Glucose, if it doesn't have insulin, is just going to pool in the bloodstream. And so what do we see there? Hyperglycemia. That means that you can have all the glucose in the world available in the bloodstream, which is going to lead to an increase in blood sugar. But if you don't have insulin to unlock those cells to let it in, then the cells can't use that glucose for energy, for whatever it needs it for. Okay, it's just going to be piling up in the bloodstream without insulin. So diabetes mellitus impairs the body's ability to use glucose for fuel by one of two ways. And so we're going to get into that and talking about what's the difference in type 1 and type 2 diabetes. So without treatment, blood glucose levels will become too high, and in severe cases, this can cause life-threatening illness, coma, or death. And so we're going to talk about what is hyperglycemia, when does it need treatment, what does it mean to be in diabetic ketoacidosis. Some of these long-term complications from diabetes can include blindness, cardiovascular disease, and potentially kidney failure as well. So we need to know the signs and symptoms of blood glucose that is both too high or too low. So hyper or hypoglycemia. And how do we treat those? We're going to talk about that. Hyperglycemia and hypoglycemia can occur with both type 1 and type 2 diabetes. So again, we're going to talk about the differences between type 1 and type 2, but the treatment is going to be the same regardless of whether it's type 1 or type 2, if it's hyper or hypo. All hypoglycemic patients require prompt treatment. So as we progress through this and we start talking about it, you're going to see that while both are dangerous, usually hypoglycemia comes on a lot faster and can lead to death a lot faster. So that's really where we're going to need some aggressive treatment. Hyperglycemia is still dangerous, but it's usually taken hours or days to get to a certain point where it becomes dangerous. And so that gives us a little bit more time and doesn't necessarily require a whole lot of treatment in the field, even from paramedic providers. So again, we'll look at some treatments as we're moving forward in this lecture, but hypoglycemia, a lot more dangerous. So looking at type 1 diabetes, this is an autoimmune disorder where the immune system produces antibodies against the pancreatic beta cells, and you're missing the pancreatic hormone insulin. Okay, so that's the key here, is that your body is not producing any, and if it is producing any, it's not producing very much insulin at all, usually not any at all. Okay, and the onset usually happens from early childhood through the 4th decade of life. So most of the time, this is diagnosed in childhood, and so that's something else that we need to know. No insulin is being produced, and it's happening and being diagnosed all the way down to childhood. And so the patient must obtain insulin from an external source. And so usually the patient will administer their own insulin through injection or maybe by an insulin pump. Okay, so we'll talk about some options for that. Many people with type 1 diabetes do have that insulin pump, and this continuously measures glucose levels and provides an adjustable infusion of insulin, but it can malfunction and diabetic emergencies can develop. So we do want to ask or check for, during our patient assessment, the presence of an insulin pump. Okay, if the blood sugar is too low and this insulin pump is still on and still delivering insulin, then nothing that we do is going to matter. So we need to make sure if they do have it, that we cut it off or completely remove it, so that it's not continuing to dump insulin in and really defeating the purpose of our treatment. This is one of the most common metabolic diseases of childhood, and with new onset patient symptoms, we're going to see things like polyuria, which is increased or frequent urination, polydipsia, which is increased thirst, polyphagia, which is increased hunger, and then weight loss and fatigue. Now, I know that seems kind of counterproductive to have increased hunger and weight loss, but it's because the body isn't utilizing glucose because it doesn't have insulin. Okay, so essentially all food that the patient is taking in is just passing right through, and the glucose stores are building up in the bloodstream, and the patient feels fatigued, but they're not getting the nutrients because they can't break them down, and that's what leads to the weight loss. So you're going to see those three things, polyuria, polydipsia, and polyphagia, many times again in test questions asking what they are and what are they a sign and symptom of. So definitely want to know what those mean. Okay, so type 1 diabetes, we can kind of see these things in new patients. So when they first take a patient to the doctor complaining of some of these things, that's how they usually find the diagnosis. So the patient's blood glucose level is going to be above normal most of the time with a type 1 diabetic, again, because they have no insulin. And the kidney's filtration system becomes overwhelmed and glucose spills out into the urine. And so this is one of the things that they begin to look for when they're doing a urinalysis, is the presence of glucose in the urine. Now that can happen if you've just eaten something, like when I was pregnant with my daughter, I just ate an ice cream cone in the parking lot of my OBGYN, and I went in, they did the urinalysis, and they said, "Oh my God, you have so much glucose in your urine." And it really wasn't because my blood glucose was so high, it was because I had just eaten that ice cream cone. So just be aware that things like that can happen, but especially if you're fasting, when they do this urinalysis and they see the presence of glucose there, is definitely a cause for concern. So again, glucose is unavailable to the cells because the insulin is not there to unlock the cells to let the glucose in. So the body begins to burn fat instead, and it starts producing ketones as an acid waste. And the kidneys cannot maintain an acid-base balance here, and so you start to have Kussmaul respirations, and the body starts to become acidotic. Now, I want to be really clear here that diabetic ketoacidosis and ketosis with like a keto diet, ketogenic diet, are two different things. So just understanding what the difference is in those two things is very important. Okay, so if fat metabolism and ketone production continue here with the presence of those high glucose, which is the difference, then diabetic ketoacidosis or DKA can develop. And this can present as generalized illness. So just maybe the patient appears fatigued, they have nausea, vomiting, things like that. That's going to be some of your first signs, because the body is constantly thirsty, asking to get rid of some of those. It's a vicious cycle. The body wants to the body wants to get rid of some of that glucose, so it's asking for water. But if you don't give it water and you give it juice or soda because you don't realize you're a diabetic, then you're just continuously increasing the blood sugar. And so you're just going to start urinating more to help get rid of some of that, but the body just can't keep up. Okay, so DKA can result in death, but this is something that begins to develop over days, if not weeks. Okay, so it's not an overnight thing. That you can develop hyperglycemia over the course of hours or overnight, but not DKA. This usually takes a few days to get to this point. We also want to check the patient's glucose level. Now, just because the patient's glucose level is over 400 does not mean that they're in DKA. We're looking for these other signs and associated symptoms as well. But remember, we're looking also for what is normal for that patient. We want to know what's their normal blood sugar run, not just what's the chart say is normal, but what's normal for this particular patient. Now, any blood sugar over 250 does require treatment per the North Carolina Office of EMS state protocols. And so if we notice a blood sugar that's over 250, we would want to call for our ALS personnel so that they can administer a fluid bolus to the patient to help bring that blood sugar down. Now, talking about type 2 diabetes, this is caused by a resistance to the effects of insulin at the cellular level. So the body here is producing insulin. It just doesn't know how to utilize it anymore. It's resisting it. Okay, so type 1, body's not producing insulin, is starting at childhood. There's nothing we can do. With type 2 diabetes, it's insulin resistance, and it's got a lot more to do with lifestyle than genetics. So we're going to talk about some of those things here as well. Pancreas produces more insulin to make up for the increased levels of blood glucose and the dysfunction of the cellular insulin receptor. So again, a vicious cycle here. The body doesn't know how to use the insulin that's being produced, but it does sense that glucose is building up in the bloodstream. So it produces more insulin, which can cause hypoglycemia a lot of times. So as soon as we start getting some of that insulin in use, now we've got too much insulin and we got low blood sugar. So insulin resistance can sometimes be improved by exercise and dietary modifications. So again, exercise, healthy diet, those things can help. So it doesn't necessarily mean that it's a cure, but some people can manage their type 2 diabetes with just diet and exercise alone. They might also need oral medications. So oral medications like metformin can help reduce that insulin resistance and help the body utilize the insulin that's present more. So this isn't adding more insulin, it's just helping the body use the insulin that's there more effectively. Okay. Now, if this doesn't work and the patient is really severe, then yes, they might start taking insulin injections or have an insulin pump, just like the patient with type 1 diabetes would if all else fails. Now, this is often diagnosed as an adult, and it can be diagnosed at a yearly medical exam for complaints related to high blood glucose levels, which may have been like a recurrent infection that just didn't get any better, changes in vision, numbness or tingling in the feet, like diabetic neuropathy. But they could have also experienced some of those other signs and symptoms like polyuria, polyphagia, and polydipsia as well, in addition to these other things. I'm going to stop this portion of the video right here, and I will catch you guys in part 2.